Hello, everyone. Welcome to At Room Now, and we are the TNF group who are so excited about the ongoing ACR 2021 convergence meeting. So I have with me, I'm Janet Pope. I have Eric and David with me, and I think you can introduce yourselves with your handle because people want to follow your tweets. So Eric?
Yes, I'm Eric Dein. I'm a rheumatologist in Summit, New Jersey. You can find me at Eric Dein, MD.
David
Excellent.
Liew,
David.
David Liew from Melbourne, Australia, and Dr. David Liew. So get on the Twitter. It's a good thing.
It is. You can learn a lot. So let's hear, I guess, Eric, do you want to tell me about a highlight today on the TNF scene?
Sure. I was going to talk about abstract 1251. So this was looking at, the big question is always, can we anticipate who's going to respond to therapies? Is there any biomarkers out there? One thing that they looked at today in that abstract is, can we use BAFF, so serum B cell activating factor? We hear about it a lot in the lupus literature, but can it predict a response to TNF inhibition in patients with RA? So they looked at 158 patients with rheumatoid arthritis initiating their first TNF inhibitor. It was a 6-month study. They only looked at them at baseline and at 6 months, compared the DAS28 levels at those 2 time points, as well as measuring serum BAFF levels at those times. They found only 24% of patients had what was considered a good EULAR clinical response at the 6-month point. Patients that were more likely to respond had lower BMIs, lower baseline DAS28s, and yes, they had lower serum BAFFs. What's a little interesting is they then broke it down by seropositivity. Patients that were seropositive ACPA patients had a good response when they had lower serum BAFF concentration compared with those that did not respond. When they looked at the seronegative ACPA patients, they did not see that differentiation. So they did a bunch more analysis, looking at the seropositive patients. They found a threshold level in seropositivity that is under 1,000 picograms per milliliter at 6 months. Then that's probably a good response, they thought, for the BAFF. And they came up with positive predictive value being pretty good at 89% and negative predictive value being only 35%. So it's showing that if you have that low serum BAFF and you're seropositive, the implication is that it's a good predictive test that you will respond to TNF inhibition. Exactly what that means as a biomarker, how well can that be used? What's the different noise in there of the differences between the groups? I think there's a lot more to learn here, but I think I never heard of BAFF being used in this context. I think it's something that is certainly interesting.
Interesting, probably not yet ready for prime time, but we don't think of BAFF signaling, although technically rituximab, although it's more B cell depleting, BAFF, APRIL, BLyS, some of the signaling pathway might or might not be altered with rituximab. So I guess it kind of makes sense.
Mm-hmm.
Hard to say though. Wait, time will tell. Yep. David, what about you today? What caught your eye?
I don't want to sound too much like a broken record with this, but I know that I've talked about the TOFA versus TNF inhibitors in oral surveillance, TOFA versus TNF inhibitors in core evitas. But today there was Canadian data from two registries combined, one from Ontario, one from Quebec, looking once again at how drug survival performed in both tofacitinib and TNF inhibitors. And what do you know? Once again, very similar performance. And actually, it did occur to me as well that it probably mirrors once again the jackpot study that was looked at today as well, which looked at patients going from who were already on JAK inhibitors and going either to a JAK inhibitor or biologic DMARD. And once again, very similar performance. So I think fundamentally, we've just got some very that all of our very good rheumatoid arthritis drugs perform very similarly. And I'll keep on saying it until people get sick of me saying it.
Well, it's good to say it. And I mean, with biosimilars, access due to cost is even probably better in many countries than it used to be. The Jack to Jack study that was 1442, I was actually surprised because I tend to think of if something isn't working, whether most things are secondary loss of effect, sometimes primary failure, uncommon, or sometimes due to side effects, less common than secondary loss of effect. I kind of thought Jack to other mechanism might do better than Jack to Jack. And you're right, it did show the jackpot study, at least adjusting for country level and things like that. They didn't adjust for all confounders yet. It's seen that Jack to Jack did just as well as Jack to other going to a biodemard. So time will tell on that. I have one study to round it out. Maybe I'll get your opinion. So Dr. Solomon and his group looked at 18 clinics, 45 healthcare professionals. It was abstract 1448, and it was treating to a target in the virtual world, and saying that treating to a target, whether you were virtual or in person did a bit better on treating to a target. And the only reason I'm bringing it up on TNF, because a lot of the background biologics were TNFs, I would imagine, in groups of just cross-sectional practices, right? So what they found was that mostly you could treat to a target either way. Of course, in person, it could be easier. So David, do you have an opinion on whether you're treating to a target or not when you're doing your virtual visits?
I'm pretty sure I'm not treating to target, and we should. I know this is something that we all need to work on. I spoke in another video the other day about how Dan Solomon's collective had actually been working on trying to improve what we do in terms of treat to target in general. That I think coaching ourselves and having kind of supporting ourselves to do that better helps. I think it's the kind of thing which I've probably let slip a bit in through virtual care, and it does worry me a little bit because I'm not for those times when I'm not palpating joints, and even if we can get a lot of a sense from virtual care as to the direction that patients are going, whether they're getting worse or getting better, and we're getting better at being able to detect disease activity. In the context of telemedicine, there's still nothing quite like actually palpating joints and detecting synovitis.
Yep. Eric, would you feel the same way?
Yeah, I think it's definitely been a little bit of a perspective shift that it started with, okay, this is just temporary and we don't need our targets. And then as the pandemic went on, I think we've had to do a change of mindset. I think this gets back to some of the research from the CATCH studies where they do the patient CDIs, and those are encouraging that it may not be the ideal target, but they're pretty good targets, and they give us something objective to go with. And it shows that when a patient reports their CDI and they count how many swollen and tender joints they report, and you use that with a physician and patient globals, as long as you're not on the extremes, they're pretty good. You know, when a patient says they're not doing well or they say they're doing excellent, sometimes there's some variation, but those are the patients you may want to see anyway. But the patients in the middle, they're usually pretty good at reporting what's going on or not. So I think it's giving you something objective to work on.
Time consuming though, for sure. We've changed our teleforms for telemedicine that say the patient's disease state is remission, low, medium, or high, and we're just ticking it by the sense we get. But obviously, I look forward to the day that you can get the visual cues, but the palpation is really important. Well, I think it's a good wrap for today at Room Now. Our TNF group is rocking and rolling, and please follow all of us at Room Now. Thank you.
Thanks, Janet. Thanks, Eric.
Thank you.